Hello everybody, welcome back to the podcast. Today we're talking about postpartum hemorrhage, and we're going to start with a definition, always helpful I think. Postpartum hemorrhage is obviously a bleed after birth, greater than 500 mils blood loss if it's been a vaginal delivery, or greater than 1 litre blood loss if it's after a cesarean section. And the reason we're talking about this is it does come up in our injured bleeding and pregnant simulations, and it's also the highest cause of maternal death worldwide. So it's quite important that we know what we're talking about and are able to treat it quickly and effectively.
The issue with postpartum hemorrhage, yes, it can lead to really high levels of mortality, but the morbidity is also really significant. Some of these individuals end up with emergency hysterectomies just to solve the bleeding issue if it's a life-threatening bleed, and actually that's a really traumatic procedure to go through and for the rest of your life. You know, it's a life-changing procedure just from that. So it's really important that we try and manage this therapeutically so it doesn't get to that stage. So what causes postpartum hemorrhage? So there are 4 T's that are easier to remember. So tone, and when we say tone, it's uterine atony. So it's the poor tone of the uterine, and this is actually the most common cause of postpartum hemorrhage, and one of the causes that there are some really good therapeutic strategies that you can do at the bedside to manage this. Second is trauma. So clearly this is a traumatic thing to go through, birth, and trauma can come from a sort of iatrogenic cause. So we could have given the patient episiotomy to aid with the birth, and that may be causing a significant issue. But also you can get quite significant uterine, cervical or vaginal tears from the delivery if it's a traumatic delivery. And again, this is something that's relatively straightforward in terms of how to manage it. It can be really significant in terms of how much blood loss you get from this, but it's something that is present and we're able to manage. So tissue is the next one, and tissue starts to become a little bit more complex because it's about retained placenta. So if anybody's had experience with the midwives and with delivery, you'll notice that when the placenta is delivered, they will check for the completion of the placenta for 2 different reasons. One, if you've got an incomplete placenta, then you're at risk of postpartum hemorrhage because that placenta sticks to the uterine wall and the blood flow just keeps pumping through. But also, if you've got retained products, then you're at much higher risk of postpartum sepsis. And this is something that, again, is quite high on the morbidity and mortality, particularly in the developing world. The last T is thrombin, least likely in this case, and usually it will be an individual where this has been picked up before. Thrombin is, if you've got a coagulopathy of some sort. So, for example, if you have haemophilia or other such clotting abnormalities. So it's tone, trauma, tissue, and thrombin. So how do we manage this sort of moving forward? Because that's really what I think gets people in simulation and at the bedside, Matt, because this is it's a really scary presentation. You've got a freshly born baby, a young mum who's got quite a significant presentation.
It's one of the true obstetric emergencies, and it should be treated with the respect. There's a reason it's the highest killer of women worldwide, and so act on it like that. Obviously, we're going to adopt an ABCD approach as we are for all our patients, but we're going to be particularly interested in the C aspect. And within that C aspect, we want to make sure we've got 2 good sized cannulas. And often a lot of the women in hospital anyway will have at least a grey cannula as a minimum when they're going in. And that's just a safety measure in case they have something like this occurring. And again, it's about having a low threshold to start the major hemorrhage protocol. Practitioners are often a little bit hesitant to activate the protocol. And actually, all you really need to activate the major hemorrhage protocol is evidence of shock. So it could be a high heart rate, anything over 120, or a low blood pressure, with suspicion or evidence of bleeding. So if you have this patient in front of you who has this bleeding and they have a high heart rate or they have low blood pressure, activate the major hemorrhage protocol. You're going to get your blood and your blood products a lot quicker if you do it like that, rather than ordering individual units through the blood bank. So I'd always advocate doing that. And just get that in as quickly as it can. So blood products, blood, FFP, tranexamic acid as well, always useful.
And I think then, so thinking about so that's a replacement strategy. And then we have to think about, again, We talked about this in a previous podcast. If you don't stop the bleeding, in essence, you're essentially filling up the bath, but the plug is out. And so you need to find the reason for why that patient is bleeding whilst activating that or major obstetric hemorrhage protocol. The most common thing, as we said earlier, is uterine atony. So it's actually about feeling the uterus, getting down to the sort of hypogastric region, umbilical and hypogastric region, and feeling for that kind of boggy, atonous uterus. And actually, boggy, spongy feeling uterus that isn't actually contracted as it should be. And actually, you can then, it's one of the amazing things in medicine where you can actually rub up a contraction, as they call it, which is essentially where you do fundal massage. So you get your fist and rub the sort of hypogastric region. Obviously, we won't go into the technique, and you can see that online. I think there's something that will probably be lost in just trying to verbally discuss it. But you're essentially rubbing up the bottom of the stomach, and you will feel the uterus contracting. You must do this with analgesia, though, because it's painful because you're inducing a contraction. So often patients will get offered some Entonox whilst this is sort of going on alongside other pain reliefs. From that perspective, it's about continuing that suprapubic and or sort of fundal massage whilst this is going on until we can get something that's a little bit less temporary and more sustaining. And Matt, what sort of things would you think about giving from a pharmacotherapeutic perspective?
So oxytocin is one of the things we use, or is used quite a lot. Essentially, it's anything to cause a uterine contraction. So oxytocin is a hormone that will do that. There's lots of other medications, so ergometrin, carbaprost, misoprostol. These are all essentially prostaglandins, or have end products that are prostaglandins that stimulate the uterus to contract. And it's all just about reducing that uterine atony. As you said, it's the most common cause. So that's often the go-to for treatment.
Yeah, absolutely. I mean, we give that sort of, there's intramuscular versions of syntropmetrin, so it's kind of oxytocin, ergometrin that's given from an intramuscular perspective from in the out-of-hospital environment. And you might see patients who have come in and had several doses of that and has kind of fundal massage ongoing. What's actually really fascinating is that getting the child to go onto the breast also stimulates the release of oxytocin. And so as a really kind of natural process, that there is a sort of feedback loop where if you get the mum breastfeeding early afterwards, then you reduce that sort of hemorrhaging. And clearly that's part of evolution. So that will also help getting the baby skin to skin near the breast.
Otherwise, other interventions you probably mentioned. So if there's a traumatic cause that we talked about, so tear, then that's going to need to be repaired surgically. So with some stitches or back to theatre. And there are other slightly more advanced things, including balloon tamponade, which I don't know a lot about, if I'm honest, or ligation. Essentially, getting interventional radiology involved to occlude the iliac arteries to stop the bleeding at the source, and as Joe mentioned right at the start, essentially a resuscitative hysterectomy, so taking out where the site of bleeding. So
there is one last ditch attempt that's quite rarely used, from my understanding, but again might be something that sort of community midwife or paramedic may have to instill, and that's bimanual compression. And bimanual compression is essentially where you have to insert your hand into the vagina, and then you have to place your hand on top of the stomach and essentially compress the uterus down. And unfortunately, once you're in that position, you need to stay there until you're in surgery. And this is a really last-ditch attempt. If none of your medications, none of your tranexamic acid, none of your uterine massage, etc., is working, and this is a last-ditch attempt to save this woman's life whilst you're going into surgery. I'd imagine it's very rarely undertaken because there are a lot of escalation methods to go up through before that happens, but it's just worth being mentally aware of in case you do see it in practice, because it will probably seem very, very alien as a procedure.
So just to summarise postpartum hemorrhage, the causes can be broken down into 4 T's, that's tone, trauma, tissue and thrombin. Remember, it's an obstetric emergency requiring prompt resuscitation with blood products and early escalation of care. Medical management includes oxytocin and ergometrin or carbaprost, or something that causes uterine contraction, and have a low threshold to put out the major hemorrhage protocol if you've got signs of shock with evidence of bleeding.